Mayor Jensen, we're ready.
Okay, thank you, Megan. Today is May 20th, 2020, and we have a work session today with the Petersburg Assembly. And to start off, I'd like to thank Carl Hagerman, our incident commander, and Phil Hofstetter, the Petersburg Medical Center CEO, for organizing this. And I would like to thank the participants from the state with us today. We have Dr. Ann Zink, Chief Medical Officer, Dr. Bernie Gilly, Chief of Public Health Laboratory, Dr. Joel McLaughlin, Chief of Epidemiology, Anna Brick, and Coleman Cutchins from Health and Social Services. So thank everybody for participating. We have 50 people, so it's well attended. With that being said, looks like the next item on our agenda today is a presentation from the state on current information and the status of COVID. So I don't know who's going to address that, but please start. Thank you.
Thank you, Mayor Jensen. I just wanted to make a correction to the agenda today. Our case presenter could not make it, so I do believe that we have probably enough question and answer to fill that void today. And should we proceed with more echoes in the future, we'll be sure to have a case on deck. So welcome everyone to the Rural Community Echo Call. Here, providers and community members have the opportunity to hear directly from the state of Alaska. So now I'd like to turn it over to our hub team. Anna, could you introduce yourself?
Hi, this is Anna Frick. I do syndromic surveillance and infection control for the state section of epidemiology.
Thank you. Dr. Zink?
Yeah, I'm Dr. Ann Zink. I'm the Chief Medical Officer for the state of Alaska, and I just really want to thank the Petersburg community for coming on. The more we can collaborate as communities and healthcare providers, the better off we are. So thank you, Mayor Jensen, for this opportunity, and to your team.
Dr. Joe?
Yeah, hi everyone. This is Dr. Joe McLaughlin. I'm the Chief of the Alaska section of epidemiology and the state epidemiologist, and it's a real pleasure to be able to be with you today. So thanks so much for the invitation.
Coleman Cutchins?
Hi, this is Coleman Cutchins. I'm a clinical pharmacist here with the state, and throughout COVID, I've been doing a lot for healthcare response, treatment, testing capacity, things like that. And thank you for your time today.
And was Dr. Bernie Gilly able to make it today? Dr. Gilly, are you on the line? Okay, I'll go ahead and turn it over to Dr. Joe and Dr. Ann Zink.
Sure. I can go ahead and start, Ann, and then if you want to kind of take it from there, that'd be great. I did go ahead and post in the chat box 2 web links that I'm hoping everybody has already seen. The first is just our web link to our homepage, our COVID homepage within the Department of Health and Social Services. And the second is our dashboard. And I just want to invite folks to, and maybe the Echo, Megan Clark, maybe you can pull up that dashboard. And
so would you like me to do that?
Oh, sure, that'd be great, Anna. Yeah, if you could, that'd be great. So Anna's going to pull up the dashboard so we can all see it.
Here you go.
Great, excellent. So as you can all see in the lower left-hand corner there, our COVID-19 epidemic in Alaska started in early March, and it peaked in mid-March. And then ever since mid-March, we've seen a decrease in cases that really kind of went all the way into sort of early mid-April. And then we saw a few days where the case counts shot up a little bit in mid-April, but since then we've been in the lower single digits pretty consistently for about a month now. We've had a number of days where there haven't been any cases that have been identified, but we are still seeing cases. Right now, we are reporting out just over 400 cases of COVID-19 that have been identified and reported to the section of epidemiology here in Alaska so far. And we've had 44 hospitalizations and 10 fatalities. So what do these numbers indicate? First of all, in terms of the total case counts, just over 402, those are the number of people who have been tested. They tested positive, and they got reported into us. Now, it's not the full spectrum of everybody who's had COVID-19 in Alaska. So what is the true number of people that have had COVID-19 in Alaska? We don't know the answer to that. And it's likely that in different communities throughout, or different states throughout the nation, the true number of cases, the proportion of cases that have been reported is probably variable from state to state. It could be that the true number of cases in Alaska is double what we've seen in terms of the reported cases. Maybe we've had 800 cases, or maybe it's triple. We just don't know. And it could be that in some communities that the true number is perhaps tenfold what the case counts have been that have been reported into the health department. So that's a big unknown with COVID-19. Even if we were to multiply this number 402 by 10, that would still represent about 1% of Alaskans that have been infected. We think that the true number is probably lower than 1%, but that gives you a sense for the epidemiology of COVID-19 here in Alaska. As things start to ease up with respect to the mandates that have been put out, we are expecting that we will see an increase in case counts in the weeks and months ahead. Our goal is to make sure that we keep the numbers under control as best we can. We certainly don't want to overwhelm any local or statewide resources, healthcare or public health resources. And so we're going to really work hard to try and keep those numbers down as best we're able. There are two main strategies that we follow to do that. One is a containment strategy, which involves contact tracing, and the other is community mitigation strategies. And we're all familiar with these mitigation strategies, such as school closures and work from home and social distancing as much as possible and personal hygiene, things like that. We know that these tried and true, long-standing public health measures have been useful in other epidemics. They've proven their value here with the COVID-19 epidemic in the United States and globally as well. And so those are the best tools we have to keep this virus at bay. Now, we're hopeful that in the future, in the months ahead, that we will have other tools in our toolbox to control COVID. One such tool would be an antiviral medicine that is shown to be, or many antiviral medicines that are shown to be effective at blunting the severity and perhaps decreasing transmission rates of COVID-19. You've all heard of remdesivir. We now have a little remdesivir here in the state, but remdesivir is one of hopefully many medications to come to help combat COVID-19. And we have Dr. Cutchins on the line here. He's one of our staff pharmacists and is very knowledgeable about antiviral medications. And so if folks have questions about that, please feel free to ask. On the vaccine front, there are many vaccines that are currently in various stages of development and investigational study. One vaccine is looking pretty promising right now. I know that there's a lot of hope around this vaccine that it may become available, by the new year. And perhaps there's even been discussion that it could become available slightly earlier than that. So we'll keep everybody abreast as we learn more about vaccine development and timelines for that. So that's sort of the introduction that I wanted to provide to sort of set the stage for this discussion, and maybe I'd turn it over now to Dr. Zink for any additional comments you might have.
No, I appreciate that, Joe, and we really appreciate, again, the community all being on here and being able to work together And we want to hear what your challenges are, what your strengths are, and how we can support you. So with that, I guess maybe I'll turn it back over either to Megan from ECHO or Mark Jensen. Mayor, I don't see many questions in the chat box as of now. I'm happy to go through more fishing plans. Coleman's on here, been doing a lot of that. Happy to talk about general topics, but I'd love to hear from you all on what you want to hear about.
I don't have any specific questions myself. Is there anyone else on today that does? Mr. Hagerman, you clicked on, so.
Yeah, I'd love to ask some questions. That's okay.
Yeah, go for it.
Okay. So, one of the struggles that we see in Petersburg is of course, trying to keep up with the mandates that have come out from the state level on a continual basis. And early on, we took it upon ourselves to issue some mandates to try and protect our population, and then since then we've kind of fallen in line with the governor's mandates that have come out and his reopening plan. But there's still a lot of concern locally about being able to retract and put restrictions in place if we do get an outbreak. In the governor's press conference yesterday, he did mention that if that were to occur in isolated communities around the state, that the state would support those communities and come in with some plans to help mitigate those outbreaks. Can you tell us what that might look like? And if the community of Petersburg is, if we should come up with a plan, which we are working on to retract, what are some of the criteria and triggers that we should look for to implement restriction and help mitigate an outbreak?
Yeah, so I appreciate that question. So maybe I'll start first by talking kind of mandates and kind of governor and state level aspects, and then I'll hand it over to Joe, who can talk a little bit more about kind of an outbreak and what we would do in Petersburg and more specifically. So I appreciate all the work that you guys have been doing. It moves so fast, and one way we've got one set of mandates and things change. Dr. Eastman, who was recently up here, had said, all of the easy decisions have been made. We only have hard decisions from here on out. And I think that there's some truth to that. It's easy to close things down. Figuring out how to open and live in a world of COVID safely is much harder. And so that partnership with you all, figuring out what that looks like, is really important. The first set of mandates were really a way to slow things down so that we could build up healthcare capacity, we could build up testing, and we could get a better understanding of this disease. And the work that Alaskans have done over that was tremendous, and that had a big impact. And as Joe was just mentioning, looking at the graph, over a month now, we've been at kind of this trickle of cases moving forward. The next set of mandates that came out were a way for us to try to help businesses open safely before there really were national guidelines and CDC guidelines out. So mandate 16, a lot of those aspects you see, and even some of our fishing mandates were a way to learn from the meat packing processing, the poultry packing, and what we were seeing there, and how to help industry get to operate safely with what we were learning, because things have just moved so quickly. So you saw a lot of movement to try to open up safely. Many of those mandates were made in combination with industry partners and others. The mandates that are still in place include Mandate 15, which includes healthcare. The travel mandates, both inter and intrastate travel, are still in place. And then all the seafood ones and fishing ones are still all in place because those were all there. What we've seen in the last couple of weeks is a tremendous increase in national guidance, including CDC recommendations. As Joe was mentioning on a previous call, we've had, over about 1,000 different recommendations on the CDC website for different businesses and different communities. And while our team can try to work with industry partners to see what that looks like, we don't know your community or your industry as well as you do. And having people be able to create that more locally and industry or business or organization specific, it is helpful. We've been trying to address it both from faith leaders, industry leaders, all these different aspects. I see some questions in the chat box about social bubbles, even individual, like how can you minimize your contacts? The protocols remain similar. We know that this virus lives by moving from one person to another, and if we don't give it the opportunity to move from one person to another, it dies, and it can't live, and we can end the pandemic. And that's by hand washing, social distancing, wearing a face covering, And those are easy to talk about. They're much harder to do when you apply them to your life and to your kids and to your industry and to your business in those aspects. So that's where the mandates are going. The guidance that came out of them, I still think is really good guidance, and they're moving to advisories, so they're not going away. The pandemic is not over. This doesn't mean have a big Memorial Day weekend party and all hang out. And so I think that there is a perception that because mandates move to advisories, we are through this, and we are in the first or second inning, and we have a long way to go. And as a result, we need to find ways to be resilient, and we need to find ways to mitigate the role of COVID, both now in the summer where we've got fishing going on, we've got a lot of people moving back and forth, and in the winter when we have schools and we have other respiratory illnesses like influenza and RSV, which can sometimes overwhelm the system without COVID. So we're thinking about those other big picture aspects when we're thinking about timing and how to move things forward. So that's the big picture. And then from what do we do if things start to get bad, we're really trying to look at a much more strategic and streamlined process. Instead of big mandates, having individuals take on as much responsibility, but then able to work through cluster outbreaks and case investigation to be able to have a more surgical approach, a much more refined approach. And maybe for that, I'll turn it over to Dr. McLaughlin. You can talk a little bit about their team and what they do specifically for outbreaks and for cases.
Sure. Thank you so much, Ian. So, you know, all of the cases that are identified in Alaska are reported into the Alaska section of epidemiology. So it's a reportable condition, and we hear about them real time. As soon as they get diagnosed, basically we get a call or get an electronic laboratory report. And we try to do contact tracing as quickly as possible as soon as we get a positive report. And I think what we've been able to do is do contact tracing within 2 hours of a report. So that's a pretty good turnaround time. Basically what we do is any new case that's reported in, we call them up and we talk through when their symptoms started. And then we go back 2 days prior to symptom onset and we say, okay, tell me about everybody you came in contact with starting 2 days before all the way up until the current moment if they're still symptomatic and still in the infectious period. And then we obtain those lists of people, and then we contact them all and we let them know that they've been potentially exposed to COVID-19, and we provide them recommendations and instructions for quarantine. So that is what is called containment. It's rapid identification and isolation of cases, and then rapid identification and quarantine of close contacts. Now, occasionally, we will hear about outbreaks and cases will be identified after a number of cycles of transmission have already occurred. For example, in a prison or a long-term care facility where, let's take a long-term care facility where you've got a lot of people who have underlying comorbidities, a lot of people with chronic conditions like coughs and things that can make it very difficult to determine if they've got COVID-19. And one of the challenges, as you all know, with COVID-19 is that very often people have very mild illness, and it can be difficult to tease that out in somebody who's got these underlying conditions. And then we're also seeing, high rates of asymptomatic illness. So people who are infected but don't have any symptoms at all, or if they do, they're just so mild that the person hardly even notices them. And so those are all situations under which multiple transmission cycles can occur and result in outbreaks. Another thing I will say is that there are some people who we call super spreaders, who have really high viral load of the virus in their respiratory secretions, so that when they cough or they sneeze or they've got nasal secretions, they're just secreting so much virus that they tend to spread it to anybody they come in contact with. And oftentimes these super spreaders are more gregarious people as well. There are a number of factors that kind of are used to classify them as super spreaders. And we saw this with SARS, with the SARS epidemic, as well as the MERS epidemic, is that with some of these coronavirus epidemics, people are super spreaders and can spread it to a lot of people without multiple transmission cycles occurring. So Anyway, when that happens, when outbreaks occur, whether it's in a congregate living setting, such as in a long-term care facility or a prison or a homeless shelter, or in a general community, especially if there's a tight-knit, smaller community, then what we do is we get involved and will assist with investigating and trying to put out that outbreak. And so we have epidemiologists who are trained in doing outbreak investigations and working with local leadership, whether it's on a community level, we would work with community leadership, or if it's in a long-term care facility, we would work with the staff at the facility to try and get the outbreak under control. Now, as we move forward with easing off on the statewide community mitigation strategies, some communities may decide to have their own mitigation strategies that stay in place for the community. And certainly, as Dr. Zink had mentioned, we do try to, moving forward, we're trying to implement more of a surgical approach to addressing COVID-19, such that if we do have increased incidents of or outbreaks that are occurring of COVID-19 in a community or in a region or even multiple regions, it might be that we can go ahead and tighten down on some of those community mitigation strategies until we get the situation under control in that community or in that region, or if there are multiple communities affected. And so that's another tactic that can come into play as we try to control COVID-19. So I hope that answers your question.
Just to follow up really quickly, if I can. So any of the clamping down of local restrictions, the community mitigation measures that you spoke of, will those need to be implemented by the locality, or will the state be assisting with that, supporting those mitigation efforts?
And maybe I'll let you start with that, and then I'll add on, if that's okay.
Yeah, so when you're talking about are we supporting mitigation efforts, can you tell me more about what you mean by that?
Yeah, thanks, Dr. Zink. So basically, as Dr. McLaughlin just mentioned, that if there's an outbreak, that there's a possibility that we would want to retract and go back to a lesser phase of the reopening plan, with community restrictions, the mitigation measures, that closing businesses, that kind of thing, restricting access to certain activities, that sort of thing. Is the state's intention for the municipalities to enact those provisions on their own, or does the state have a plan for those types of things?
So every municipality and region has slightly different legal authorities. So some have their own health authorities, some don't. Again, a lot of our tribes have nation-to-nation agreements, so it gets into a lot of lawyer conversations very quickly to see what that exactly looks like. I think that broadly, from a state perspective, we support the idea, and the governor supports the idea of local people know what local government and local things look like best, and what ways we can support that is great. We do want to be mindful to make sure that local communities who have resources like a critical access hospital don't close off if they provide a resource to the surrounding community that they couldn't otherwise access. So there are some limitations that have to happen with that. But besides that, yeah, I mean, I think there is effort to try to make sure communities can figure out what that looks like. And we are here to partner with you throughout this pandemic. We're not going anywhere. And so, does this mean we close down schools in your Joe and I were just on a call with all the superintendents today. They had the same question. Does that mean schools? Does that mean a business? Does that mean travel? What does that look like from all those different aspects? So I think it would be a case-by-case situation. We've done it with certain businesses already where we've said, listen, we're seeing an outbreak here. We're asking you to shut down for a period of time. And so that's an example of how we'll have a finite kind of local, and we broaden out from there. So.
Right, and I would just add that we're available for consultation as well. And so if you're brainstorming, if local leadership is brainstorming, what are the community mitigation strategies that we think would be most helpful in our situation, we've got an outbreak happening in the community, then, certainly we're always available for phone consultation or, an echo meeting or whatever you need.
Thank you both very much.
No, great questions. Looks like we've gotten a bunch of chat questions showing up in the chat box. Do we want to try to go through these?
Dr. Zink, do you want me to summarize some of these for you? They're from Israel Medical Center, at least on the medical side. So the first one is a good one. It's related to lab, and we're really having some struggles getting reagents and supplies for our lab testing. We have the availability to do some testing since the end of March, but we've been unable to get reagents to perform the tests. And so we have submitted up through the chain, obviously, and the question is, do you have a plan? There's a two-part question. The first one is, do you have a plan to support rural communities like Petersburg who do not have other partnerships and support to obtain the necessary reagents? And then the second part of that question is related to the Abbott ID Now machines, which have a higher false negative rate. And the current guidance from the state advises to choose the guidance from the state advises physicians to choose the best turnaround time over the sensitivity of the testing platform. And so I guess the question relates to determining when to use the test appropriately, and should the turnaround time be the determining factor over the sensitivity?
So great. I kind of see that as three questions, and I will start with one, and then maybe Joe, and then Bernie. So for what we're doing on a federal level to get you reagents, this has been a high priority for us. We have been talking to the White House for a while there. It was almost on a daily basis. We have access to the fact that you have that machine and you don't have reagents for it. And that's starting to become kind of a federal priority to try to get reagents to our small communities so you're able to run them on your own. The reason that we kind of supported getting Abbott tests out to the communities is just because we knew that you didn't have reagents. We're being told nationally to make sure that you have a variety of platforms to work off of. And that's why we're trying to kind of support all the different mechanisms out there. We do have a testing strategy, and we have to submit that nationally on what that looks like. And having access to community testing is a critical aspect of that to be able to have a rapid turnaround time. Each of these tests can be used a little bit differently, and so that's kind of the big picture. The other two questions that I kind of hear in that is a little bit more about the testing strategy and then the Abbott specifically and the sensitivity. So maybe Joe, first one, and Bernie, second one.
Sure, this is Joe McLaughlin. I'm not sure if Bernie's on the line or not. So here's what we know about these various tests is that they have different threshold levels of detection of the viral RNA. And the RNA is the genetic, this virus doesn't have DNA, it has RNA. So basically these tests are able to detect specific codes on the viral RNA. And so the State Public Health Labs test is able to detect about 3.5 genomes, RNA genomes of the virus per milliliter of specimen that's collected, of fluid. Some of the other tests that are out on the market have a different level of detection where some are in the 50 to 60 range, some are in the 100 or even 200 range. So one of the tests might only be able to, the lower level of detection might be 100 genomes per milliliter of fluid. So in this case, the lower the number, the more sensitive or the better the test. Now, one of the things we don't know, however, is these various levels of detection, we don't know how they relate to true clinical relevance. So we don't know for sure if a test has a 3.5 genome per milliliter threshold and another one has a 100 genome per milliliter threshold, is that actually clinically relevant? We don't know yet. And so until we have that answer, what we're saying is the best thing to do from a clinical standpoint is to use the test that has the fastest turnaround time. Because the quicker we diagnose people with COVID-19, the faster we're able to get them into isolation and prevent transmission to other people. And then to do contact tracing and get those contacts into quarantine. There's one exception right now. I'm sure many of you have heard about the Abbott ID Now test, which has been shown to have likely have lower sensitivity than some of the other tests that are out and available. And so what CDC recommends is they don't recommend stopping using the Abbott ID Now, because if you have a positive test result from the Abbott ID Now, what we're hearing is that, yes, you can trust that. It's a true positive. It's most likely going to be a true positive. But if you have a negative test result, that doesn't necessarily mean that the person is not infected. And so what they're recommending, CDC and others, is to go ahead and send a specimen from a negative test into a lab that can do a more powerful, can run the specimen on a more powerful analyzer or machine, such as the one we have at the State Public Health Laboratory. So I hope that answers that question.
Yeah, this is Bertie Lee, director of the state lab. I did finally make it on, had a little bit of computer glitch. But, everything that Dr. McLaughlin said is absolutely true. And that's why we early on recommended or asked anybody who's using the Abbott and Cepheid kits to send us the remainder of the specimen or the extraction fluid, or if we have the luxury of actually collecting 2 specimens from the same person, sending that to the state lab, because we do want to keep the tabs on the performance of these, what I call near-patient tests, because of the early reports of false negatives, and of course now later on with these published that the Abbott has really performed below par of what was expected in high incidence states. So far, we have tested over 350 duplicates and found only 2 discordant results. The one discordant result was a false negative with the Abbott ID Now, and in our hands, when we looked at the viral load in that particular specimen, it was right at the threshold of detection, limit of detection for the Abbott test kit. And as Dr. Joe mentioned, that it does have a higher lower limit of detection than either the Cepheid or the reference method. So that was not an unexpected result. The other one was with the Cepheid kit, where the Cepheid was positive and our reference method was negative. And when we retested that with our Cepheid kit, it also came out negative. And that may have been just due to viral degradation in transport. So we're really not counting that as a discordant result. So really, 1 out of 350 is not bad at all. Actually, it's pretty gosh darn good. So, our recommendation is, just like CDC's, is to go ahead and continue using it. But if you really have suspicions or something just doesn't feel right to you, it is recommended that you send it up to the state lab, and we do have usually a 24-hour turnaround time from getting into the lab.
Okay, thank you. I think one of the follow-up questions to that piece was related to procedures and performing an Abbott ID before doing a procedure. Is there any concern about the higher false negative rate on that?
To clarify by procedure, you mean the specimen collection process?
I believe providing a test before a procedure, like a medical procedure.
Oh, I see what you're saying. The performance of both the Cepheid and the Abbott ID Now on asymptomatic patients or patients of low probability has still not been officially established and sanctioned by the FDA. So if at all possible, those kind of specimens should be sent to a lab that uses the reference method. I know 48 hours is a really tight turnaround time, particularly from Petersburg. But if that's all you have, that's all you have, and go for it.
So maybe I'll just follow up a little bit on that. So there are clear ways they can be used, but as Bernie mentioned, it's a little bit hard to know how useful they are or not. Again, a positive is very useful, a negative. But if you have a low suspicion on that patient as well, You'll see in Mandate 15, there was some changes to the dental procedures, and we're hopefully rolling out a little bit of changes to Mandate 15. The biggest thing that I just want to emphasize is using clinical judgment associated with these cases as well. The more that we can be looking for cases and screening and making sure that our healthcare community is protected, the better off we're going to be. If you have a traveler who recently came in from the area, from Anchorage or maybe Seattle, and they have appendicitis and they're going to need to be intubated, I would use the Avid ID because they need to go right then. I can't wait 48 hours, and I'm going to be doing an aerosolizing procedure, and they have higher risk for travel. If I have a little kid that's been living in Petersburg, there's been no other cases, and they're getting a dental cleaning that can be otherwise mitigated, and the test is going to be challenging, then I would consider holding off on the test altogether. I think that there's a lot of variability there, and everyone wants a very clear outline, but as we all know, medicine is a little bit more gray than it necessarily is. So you can use the Avid ID now, as Bernie said. If you can use the state one, even better, but use your clinical judgment.
Thank you. So there's a couple of questions on social bubbles, if you can expand on that, and what are the recommendations for friends' homes and and recommendations for doing it safely?
Yeah, so maybe I'll start with that one, and then Joe, if you've got any other comments on this, I will tell our PR team, PIT team, that you guys asked about social bubbles because they put a lot of time and effort and thought into this one, and appreciate the fact that people are watching them. Again, it's all about risk and what risk you and your family are willing to kind of take, and what the risk looks like in community, and then also making sure that you are finding ways to be happy and healthy. I get asked, is it okay for me to kiss someone these days? Can I hug my grandmother? You know, the state never set out parameters for all of those different things. In general, the more that you can mitigate your close exposure to other people, the more you protect yourself. So I think thinking about who is in your bubble. So in my family, it's my family who's my bubble. That's who's in there. But if there is another family that maybe has an older person, like a teenager who could help babysit, and that would make your life much more functional, and you can deal through this pandemic much longer, then that may be really reasonable to consider opening up your bubble. The idea behind a bubble is kind of expanding who is in your close, and I kind of think of it as shared risk. So who are you willing to share that risk with you? And you also have to think about who's in your bubble to think about, are you willing to open up that risk? So if you have an elder in your bubble who has a lot of underlying medical conditions, you may want to keep your bubble a lot smaller and the walls of that bubble much tighter. So not be moving in and out a lot. You may also want to consider the jobs in that bubble. So if you have people in your bubble who are working in the healthcare sector, working at a grocery store, working with the public on a regular basis, your bubble is more porous just by the nature of that job, and so you may want to consider keeping your bubble smaller. If you are a single individual and your bubble has just been yourself for some time, then thinking about opening up your bubble to a group of 3 or 4 girlfriends who have a similar kind of risk, and you're willing to kind of take that shared risk. It's a framework to think about how to make this sustainable and long-term, and also minimize your exposure and risk. Other ways to be thinking about it are thinking about keeping track of the number of people or interactions that you have in a week basis. If you can think about the number of interactions you've had in a week and you were able to name it all, you're probably keeping your bubble pretty small, and that's great. If you can go to your grocery store once a week and then the hairdresser the next week, rather than doing each one every single day, that also reduces your risk. So it's all kind of about risk tolerance and thinking about how to do those bubbles. So we went through in the blog post a whole bunch of different ways, and there's a paper on it. New Zealand really kind of moved along this concept. Canada has also been doing it well. There's a paper from Oxford that talks more about kind of the social bubbling, and again, it's that idea of shared risk and risk tolerance, so that you can find ways to move forward. And remember that those personal mitigation strategies are still really useful even in your shared bubble risk. So it doesn't mean that hand washing doesn't go out the door. Having a dinner party with your friends outside rather than a dinner party inside, and making sure that your groups stay small and consistent can be helpful. Juno did a really nice little video, I thought, of how to be thinking about kind of mitigating your risk. We've been sharing that. Feel free to take a look at that. Joe, any other comments on that one, or other questions that you guys have on bubbles?
No, I think you did a great job of responding, Ann. Thank you.
Phil, does that answer most of the bubble questions, or were there other specifics that I...
It seems like it does answer most of them. There was one addition with about children under the age of 2. Any tips for continuing to protect children under the age of 2?
Yeah, great question. Children under the age of 2 cannot do social distancing. Like, it's in their nature, put everything in their mouth and to lick you. all the time. So we just have to recognize that that's just who they are, and finding ways to let them be the little people that they need to be and have continued ongoing learning and development, which is really important to have sensory and tactile learning and to be in person and close contact. And so that's a case where you may want to think about opening a bubble to an in-person daycare person who could be coming to your house and helping to have those really important in-person interactions, or opening up to another family who has an older person can help care and interact with that child. So again, we all have different needs as humans, and we need to make sure that we are recognizing and validating those needs, and then also recognizing we have limitations. Kids, 2-year-olds should not be wearing, kids under 2 should not be wearing masks, and they need a lot of human interaction, and so finding ways to honor that.
Okay, great. Thank you. This question comes up often. It's chloroquine, and so there's some suggestion here that it's a successful treatment and why it's not being used. Maybe some clarification on that treatment would be helpful.
Yeah, Coleman is our resident pharmacist.
Hey, thank you. Early on, chloroquine and hydroxychloroquine received some media attention, and there have been a few studies that are currently underway, and then actually a few that have been stopped early. I will say that it hasn't been studied at all in terms of like first-line peer-reviewed articles for any outpatient treatment. It's only been studied inside the hospital, and even more specifically in the ICU setting. And since then, actually, the FDA and the CDC have both released statements saying that there are quite a bit of risk associated with it. And coincidentally, a few of the trials that are underway in looking at it had to be stopped due to serious cardiac events, mainly, QT prolongation and arrhythmias. So I think now we're actually trending towards, pretty good evidence that no first-line medical trial yet has shown it to be effective, and that also there is a pretty significant harm associated with it. I kind of remind everyone that, just being over 60 and being on that drug, hydroxychloroquine or chloroquine are actually 2 risk factors for QT prolongation. If you add azithromycin, that's a concurrent drug interaction. And in the hospital setting, we would recommend that person be on telemetry. So that's kind of where we're at for hydroxychloroquine and chloroquine.
And I guess I'll just add, there's always that patient-physician interaction, and that there's hydroxychloroquine is an important drug that's used for other autoimmune diseases, and there are real rules for it. And so really talk to your primary care doctor and provider. It was initially a part of some of the protocols, as Coleman mentioned, and at the end of the day, we really want to empower physicians and PAs and NPs and providers to make the best decision they can. And we have a series of echo calls similar to this one to help providers all learn from each other regarding COVID, because this is a new disease process. This topic comes up there as well. And if there's any other medical providers on the call, particularly the Tuesday night ones, we have case presentations and have some more robust conversations about things like this. So thanks for the question.
Okay, I'm going to combine a couple of questions related to seafood and cannery workers. With the increase in visitors and seafood workers, would you expect an increase in positive tests? And coupled with that, should there be some rules and procedures that are specific to COVID that we could be looking at as a municipality to help with protecting the local community?
Yeah, great question. So whenever we have more people, whenever we have more travel, and whenever we have people working or living in tight, close quarters, we expect more cases. And the fishing industry fits many of those criteria. So we've been working hard with our federal partners as well as our industry partners to try to mitigate that risk. I would encourage people to take a look at Appendix 1 of Mandate 10, as well as Mandate 17. Those were attempts to try to take a lot of the processing and a lot of the information and mandate safer ways of being able to mitigate the disease as a whole. I would also encourage people to take a look at the CDC guidance for meat packing plants and poultry packing plants. Those, I think, fit pretty well with seafood processing, and so those are the other things that we are encouraging those industries to do. We also are working with the CDC on a webinar that we will be doing with the industry on Friday and have been doing a lot of calls with them. I think there's a lot of work that's happening in the background that hasn't been totally transparent, and part of the reason why we appreciate these calls and this question specifically, so you can hear a little bit more about what's been happening. First of all, we're encouraging companies to quarantine for 14 days outside of the state of Alaska and test at the end of that. That is a strategy that has been used in some of the companies. The idea behind that is the 14-day quarantine period is our best tool at seeing if someone starts to have symptoms, and then that test at the end to make sure there's not an asymptomatic carrier to mitigate that risk if someone's coming into like a meat processing or seafood processing where it's hard for them to be distanced from other people and there's higher risk of entrance. Many of them are doing that, and they are getting positives in the lower 48, and they have been sharing that with the other industry partners. So those aren't showing up on our numbers, those aren't showing up on our press conferences because they're not Alaskan numbers, but it's part of the work that's being done behind the scenes. Some people are doing a test in Seattle prior to coming up, and that is also catching a number of cases that is there. And then there's kind of two other options. Some are quarantining in Anchorage for 14 days prior to moving into a more remote or rural community, and some are quarantining in community itself. We're trying to pool as many of those tests as well as much of that quarantine in larger urban areas because it's easier to run a whole lot of tests in those urban areas than it is to staff up every rural area with the testing capacity that would be needed. So if we're looking at 60,000 workers who are coming in, if we can do those near Seattle where they can process 5,000 tests a day, it's much easier than setting Petersburg up or other places up for that degree of testing. That being said, we want to make sure that each community has testing ability and is able to kind of screen. I think it's also important to realize that quarantining and testing is one strategy, but we're working a lot with the seafood processors as well as others on the other personal mitigation strategies. So plexiglass walls to separate between them, PPE requirements. We continue to work with the federal government to support them to get federal supplies to do that. There are their testing and their procedures and protocols in place, and many communities have taken a look at those. I would say that those are kind of the basics, and then there's been a lot on top of it. We have found that most of the community partners have been really good, and the industry partners about sharing that locally. And so if you haven't, you're always welcome to have an industry call with them. And then Coleman, he's been coordinating a lot of this testing in industry. Coleman, do you have any other comments that I've missed on that topic?
No, we are, working specifically first with the individual communities that are, the fishing industry started first. Also around that, we do currently, as of Tuesday, have a testing facility up in the Anchorage airport for travelers who are going through those, so they can use it if the communities are requiring a test result before they can be deployed to their community. I've had a few conversations with the healthcare providers there in Petersburg, and we are setting up avenues to set you up for success in terms of a testing strategy and getting what you need to be able to test your community and the influx of people coming in.
And one other thing that I would add is something that has seemed to be successful in other communities at understanding the flow in as well as making people feel safe. Is setting up some sort of tent or a greeting stage as people are getting off of planes and coming in, because a lot of them are carrying negative test results with them or proof that they've done quarantine, and that way people can have a sense of what's coming in, what's not coming in, helping to educate them on local protocols such as, you can't go to our grocery store during your 14-day quarantine, but we'll deliver to you. Or we've seen different communities find other mitigation strategies. And I think that's helped communities feel like the process is working and safe. It's helped communities identify when it's not working so that we can work through that with you, as well as I think that just that really active ongoing education. We've seen communities use their CARES dollars to actually employ people to do that. We've seen people use volunteers in combination with their local security and or police to kind of encourage that effort. And so I don't know exactly the best way to make that happen in Petersburg or what you guys are doing along those lines, but we have seen that when that seems to be working in a community, people seem a little bit more comfortable, and we're getting kind of consistent feedback on what's working and not working.
I'll respond to that just a little bit. That's where reagents and supplies will really be helpful for us to be able to apply some of that testing capability. This question is a few parts to this question, and it's related to, is there any new information about COVID and the way it spreads or affects different people that is informing these decisions to change the restrictions to daily life and businesses at the state level?
That's a good question. So I think that, again, the restrictions that were put in place were to build up healthcare capacity and testing. And then the second set of mandates was to find ways to open them up. I think that our understanding of this virus continues to change, and that we learn stuff about it every day, everything from the way that children are infected, the way that asymptomatic spread can happen, the super spreaders, as Joe mentioned, what those things look like. And I would suspect that we will continue to learn quickly about this disease for years to come, and we'll continue to adjust that. I don't think that there's been such significant changes in the disease itself that it's changing the way that we are issuing mandates or restrictions in the state. I think what's changing is our healthcare capacity, our testing capacity, as well as trying to settle into a new set of normals and using the summer as a time to kind of figure out how to do businesses, how to figure out your social bubbles, how to figure out how to maintain and sustain this before we get into flu season, RSV season, and potentially school. Thinking about those as all kind of risk factors for what this looks like. Quarantine fatigue and mandate fatigue is real, not just in Alaska, but across the world. And not only does it have tremendous impacts on the economy, but it has impacts on all sorts of other aspects of health and delayed health care. It's important that people are making sure they're getting preventative care, and we're finding ways to think about the whole person moving forward. So it's more thinking about long-term, how do we maintain this, than it is really a change in the virus. Joe, any other thoughts on that and the virus itself or our understanding of it?
Yeah, I think one of the big unknowns that we're starting to get a better sense for is the contribution of asymptomatic carriers to potential transmission. Early on, when we were first trying to grapple with this in the United States and globally, there was really not a consensus as to whether or not asymptomatic transmission was occurring. And now it's been well demonstrated that asymptomatic transmission does occur. We know that people are most infectious right around the time when they develop symptoms. So usually 2 days before symptom onset, going 2 to 3 days after symptom onset. And unfortunately, this is the time period during which people who present with symptoms are the most mildly symptomatic. They have very mild cough or very low bump in their temperature, maybe even, in the high 99s, not even getting past 100, or they'll have a runny nose, or they'll just feel a little bit off, maybe some myalgias, muscle aches, some joint aches, things like that, but just mild. Now that's when they're probably releasing the most virus from their system, unfortunately. And so that's why we try to identify cases as quickly as we can, get them tested, get them in isolation, and then we do contact tracing to find those close contacts so that when they develop symptoms, when they're in that pre-symptomatic period and the early symptomatic period, they're already in quarantine, and so they're not going to infect a whole bunch of other people during that time period. So I think that's one of the big things that we've learned in recent, in the last month or so. We're getting a better handle on the asymptomatic and pre-symptomatic transmission and when the viral load or the viral shedding is the highest. So I think those are kind of the big things. We still don't know what proportion of people who are infected will develop symptoms. On the whole, at the population level. Some people have said, well, maybe it's 20%, and others, well, maybe it's 30%, and some people have gone as high as maybe it's 50%. But the bottom line is we just don't know. And it probably varies from community to community depending on the composition of people within the community. If you've got a lot of people who are in the higher age brackets or who have lots of underlying conditions, you might see higher rates of not only people who have symptoms, but also people who have more severe disease. Certainly we're seeing that people with underlying medical conditions and people who are older are at higher risk for severe disease. But we're also seeing in certain pockets of society that there are differences by demographic factors, socio-demographic factors. For example, I'm sure all of you or most of you have been reading up on the fact that we're seeing a higher incidence of COVID among African American people, and that is more likely due to socioeconomic factors than strictly race. So I think those are some of the other things that we're learning about this virus that we've learned in the last several weeks.
Okay, there's a few questions on, I'm going to try to group them on testing, and both on how often should you test someone in a vulnerable population was one part, and then the other part was about surveillance testing, specifically, is there any surveillance testing for sewage or antibody testing, and how would that work?
So I am actually going to have to pull off, and those questions are fantastic, Joe, if you don't mind. And I guess I would also say I know that we're running close to the end of time. Megan from the ECHO team can also happy to take any questions and forward them to us because there's some great questions in here. I'll make sure they're going to get answered. So I'm sorry I have to pull off, but Joe, I'll hand it over to you and Megan to summarize and to follow up. Thanks, guys.
Sure. Thank you so much. So in terms of the question about sewage, what we've seen out of Holland and some other areas is that testing sewage they've been able to find the virus in sewage, in some cases in communities before cases have been identified. In terms of the cost effectiveness of that approach and the true utility of that approach, I don't know that that's been definitively that question has been definitively answered. In terms of frequency of testing, can you repeat exactly what scenarios we're talking about for frequency of testing?
Yeah, I believe the question is related to asymptomatic testing and how often should you test somebody, whether they are a healthcare worker or a vulnerable population.
I see. Okay. So what I'm going to do is put our testing guidance in the chat box, and let me just pull that up real quick here. And then that really provides our guidance with respect to asymptomatic testing. Now, CDC has come out and basically said in terms of frequency, that has not necessarily been worked out. For example, if we're going to go ahead and test people in long-term care facilities or in hospital settings or in prisons or other such congregate living situations, how frequently should those people be tested in those situations? CDC has not definitively given an answer on that. So what we recommend with respect to our testing guidance is that there are certain circumstances under which asymptomatic testing is warranted, and that is on the first page of our testing guidance, and we say it would be warranted per the mandates. So we've got Mandate 10, Mandate 15, and Mandate 17 that have specific address specific circumstances under which asymptomatic people should be tested. But then we also say other settings where asymptomatic testing may be considered include close contacts to confirmed COVID patients, healthcare workers in hospitals and congregate living settings, residents in congregate living settings, and then other high consequence settings such as people maybe in a remote community, in areas where COVID-19 is circulating. We might think about doing asymptomatic testing. Oftentimes, what we've done most frequently with respect to this, in terms of decisions that we've made by the section of epidemiology, has been around congregate living settings where we decide to go ahead and test a large number of people, if not everybody, in a long-term care facility, for example, or in a prison setting. But I'll go ahead and send around this testing guidance so you all have it. I'll put it in the chat box.
Thank you. Thank you very much. As we prepare to wrap up, I just wanted to share with everyone on the line that we do have a box folder. I put the link in the chat box that'll allow you access to videos, resources, and links from all of our echoes. We have an echo similar to this that occurs twice weekly on Tuesday and Thursday afternoon. The link for that is also in the box. Thank you everyone for joining, and I will now turn it over to Mayor Jensen.
Okay, thank you everybody for participating today, and thank you, Megan. And I see there is a list of questions. I think we covered most of them. Phil Hofstetter grouped them together nicely. So that's 2:31. So with that being said, I guess I'll sign off. Thanks everybody for participating.
Great. Thank you so much.